Hello guys, welcome back again. We have finally come to the end where we're going to talk through the 15 minutes non-stop stations, the non-physical encounters in Newcastle University. And what we'll talk about today is that we'll go through the structures of spikes, as well as the potential scenarios that you might be given. We will touch a little bit about palliative care and DNA CPR. And we'll go through the results that I got, mainly in the ones that I failed in the first attempt, and some mindsets about how to survive this non-stop talking, okay? So first of all, for spikes, this is a structure that I didn't know of when I was doing the first attempt. And when practicing with the people who are resitting, some of them introduced me to this structure, and I realized that Newcastle University actually expect you to do spikes a lot. So we'll talk through them and explain what kind of things we should be aware of. So first of all, for settings, it means whether the room is quiet enough, the chair, whether it's set in a proper positions, like facing each other. In an exam situation, you don't really need to do much about it because the room is being set for you. You're walking into a foreign room that it wasn't you who prepared for it. But in actual real life, as a foundation doctor, I heard that we need to do quite a lot of explanations for treatment or DNA CPR, palliative care. So setting is very important in real life situation. Perception wise, it's about taking the brief history and again, using the open question to understand what their story is about. During my second attempt, my job was to explain the PEDS atypical UTI kind of investigations for grandma. And just after I introduced myself, the grandma picked out a list of questions and started firing all kinds of random questions to me. But don't be afraid, still try to bring them back and take a brief history. First of all, it will help you gain some insights about what they're understanding about the situation, what the management and investigations being done for them, as well as it helps you gain more control about the structures, and which will lead on to the invitations after the brief histories. So again, in Newcastle University, you have to do ICE. So you ask, what's your knowledge at this current point? Is there any particular worries that you have? Other than explaining what this is there anything else you want me to do for you? And now it's the time for you to have a warning shot if it's gonna be quite difficult or if it is a bad news. So you could say like, so what we'll talk about today, it can be quite difficult and sensitive. Do you want to do it today? And do you want other people to join in, other family members or friends? And same as results as well. So you would tell them that unfortunately the result isn't what we're hoping for. Do you want to do it today or do you want to do it in the future? But of course, the patient is going to say they want to do it today, or else there's no need for the exam, right? So they'll say, yeah, let's do it today. So going on to the knowledge part, what I like to do now is that I would like to explain the structure of what I'm going to talk about today so that they won't interrupt me in the middle and asking me the question that I am supposed to explain in the future or in a later time. Because during the first attempt, my station was explaining an endometrial cancer risk to a postmenopausal bleeding woman. And just when I was explaining the ultrasound for her vagina, checking the thickness of the endometrium, she stopped me in the middle and asked me whether I'm gonna refer her to a specialist. And I was about to explain to that in probably 10 seconds later, and she stopped me in the middle. And not to mention that in the feedback, the examiner wrote like, the student has to be prompt about specialist referral, which could be quite annoying. As a result, what I prefer to do now is that I explain to them that what we'll do now is that we'll explain what this is, why it is important to treat it, the investigations and management. And I'll also mention at the start that don't worry, I'll provide you with a leaflet at the end to have a read, so you don't need to recall every information that we talk about today. And of course, at the end, give them the permission to stop you to ask some more questions, which can be sometimes a bit annoying and irritating. Just like, come on, let me finish it. When it comes to management, just remember the safety netting. So if there's any new questions, if you notice more bleeding from your vagina, if you notice some fever, it's feeling unwell, make sure you come back to us. We'll have a checkup, as well as explaining the MDT referrals. So who will be involved in the patient's care, like Macmillan nurse, OTPD, STs, those kind of different services, and conservative management, the lifestyles, explain what kind of things could be done and educate them. In Newcastle University, they still want you to chunk and check. So after explaining each section, either stop and ask them to repeat. So I've talked quite a lot just to make sure that I explain everything correctly. Can you repeat it back to me, what you learned about this condition? And my personal view is I do the repeat thing once only, and later on just ask them whether they understand, are they able to keep up with it, is it okay if I continue? So that the mark scheme, they will take the chunk and check as well as repeating as well. When it comes to explaining the potential differentials, at the start I didn't know how to do it, because should I explain everything? Like, oh, you might have meningitis, you might have septal hemorrhage because you got this, and that, or how much details I need to talk about it. So I learned this phrase from my friend. So she said that it could be many things been going on, such as, so that you give them some milder conditions like UTI. No, sorry, let's say the postmenopausal bleeding. It could be many things going on, like some trauma to your vagina, HOV vaginitis. But there are something that we are worried about, which is the main topic of this station. So for example, it would be endometrial cancer, lung cancer, or MS, PD. And that's the thing that we need to check up, so that you can focus more on the condition that you stressed on, compared to other minor stuff that you could quickly roll it out with all kinds of investigations and they won't ask that much questions about it. So that's quite a good phrase for introducing the differentials that you have in your mind, as well as stressing the main character of the station, which could be like all kinds of random cancers or CKD, things like that. So empathy means some silence or chunk and check. So is it okay if I continue? And for silence, I found it quite useful when it comes to waiting for the patients to come back after explaining the differentials or the bad news. So it could be the chest X-ray shows that the lung cancer has spread, and it's a very bad news. You tell them it will take some time for the patients to come back to take in the results. So some silence would be quite useful for them to have some time, have their own space. And that's what I like personally. If someone explains some bad results to me, instead of the doctor keep talking like, are you okay? Do you want me to continue today? Oh, I'm very sorry for this to happen to you. I prefer the doctor to be quiet for a bit. So probably about 10 seconds of silence, 15 seconds of silence is quite a good space for them to process the information that you have given. Finally, strategies and summaries for spikes is, again, at the end of the explanations, you can have a brief summary. So you can say, a brief summary of what we just talked today. We mentioned that what GDM is, what kind of management we will do, We'll have more scans to help with you and some management for that. And I'll provide you with the leaflets. Is there any questions or concerns at this point of time? So that's quite a good summary to have a quick overview on what you just talked about today. And then finally, before you end the consultation, you could offer to explain the situation to the family member. And oftentimes that could act as quite a good empathy and add on things that you could do for the patients. So going on to explanations and potential scenarios that you might be given. So first of all, for investigations afterwards, postmenopausal PB bleed, the veneer was like a 60-ish years old female with a postmenopausal bleeding, past medical history of nothing, medication of nothing, and on examination, the vagina looks normal and the structure looks normal. And your job is to explain the next step forward and address any questions or concerns from the patient. So the aim of that station was to explain the fact that it could be atrophic vaginitis as the most common cause, but the most worrying part about it is the endometrial cancer. So that's why we need to refer to specialists, more investigations, and if the patient asks about management, like let them know about chemotherapy, surgeries, those kind of specialist management. But reassure them that we would support her throughout the way. We will address as many questions as possible, but if she wants more details about it, ask the specialist. For Pete's atypical UTI, it was for example, 6-month-old baby John, and grandma is here. Baby John had a atypical UTI, and we are there to explain the investigations onward. So it will involve the MCUG as well as the MSA scan, I think, where you check the kidney scarrings and potential VURs. For Pete's febrile convulsion, that's what I got in 3rd year, and it was quite a straightforward one. It's mainly about safety netting and knowing the potential risk of it becoming an epilepsy. So the mom will ask you, I'm very scared that baby Rebecca is gonna have a epilepsy. What's the risk of this? What's the risk of her getting a seizure again? So reassuring and a lot of mental support and follow-ups can be quite helpful for her to feel more safe and feel reassured. Okay. For management ones, I got GDM for the 2nd attempt. So explaining what GDM is and the management for that. I forgot that first of all, her results was that it's a 28-year-old female with 28 weeks of gestation. Her fasting glucose was 5.8 and her OGTT, so 2 hours later, glucose test was 7.9, I think, millimoles per liter. And I forgot that for management of GDM, it's fasting glucose less than 7 millimoles per liter. It's mainly conservative management. And if it is more than 7, it's insulin plus minus metformin. So I gave a lot of information about insulins and metformin and didn't stress that much about the conservative lifestyle diet changes. So be aware of that. This is just a mistake that I made. In regards to CKD and dialysis pros and cons, don't worry about it. It was a year 4 explanation stations, but it's what we call as a pre-release stations. So the school will release the veneer of that station about 2 weeks prior to the actual exam for us to have a read about the NICE guidelines, go through the management about it and the criterias. My recommendations for that is that you practice all kinds of situations with your friends in these kind of pre-release stations. If lucky, you could get quite a good, nice patient who doesn't have any questions, but then you may get a patient who has a strong preference for a certain type, and it is really crucial for us to explain the pros and cons about that, the potential risk factors and infection risk, things like that. Contraceptions wise, I got one in year 3, and it was I think it was a learning difficulty female who wants either Mirena coil or copper coil. I can't remember what she wants, but again, do a brief history about why she wants it and some cardinal symptoms of any period problems or STIs. Double check about the pregnancies and menstrual periods, and go through the pros and cons about it briefly, and let them choose whatever they want. The hard part about contraception is that there's lots and lots of things to explain. So the pre-explanation about the structures of that what you're going to talk about is really, really important, you might say. So it sounds like you have a strong preference about the Mirena coil. So what I'm going to do now is I'm going to explain to you what Mirena coil is, the risks and the benefits of it. But after that, if we have time, I'll explain to you the copper coil, as well as the pills that you might want to take as well, and we'll provide you with the leaflets at the end, so that the patient knows that we will focus mainly on the one that she wants, but if we got time, we will touch on other options briefly so that she has a better understanding about them. Finally, about the scenarios, breaking bad news such as DNA CPR and palliative care. The hard part about it is that the wordings of it, as well as it being involved about life and death, can be extremely difficult and sensitive. The patient or the family member may have a spectrum of reactions, from the easiest ones, accept and being very nice to it, to crying and disagree, angry, frustrations. So we'll talk a little bit about DNA CPR as well as a palliative care, okay, on the side. So first of all, for DNA CPR, are you able to see? Okay. That should be good enough. So for DNA CPR, let's say we got a simulated patient of 85-year-old male called John Smith, who has a past medical history of stroke, MI, and he is in the hospital due to a chest infection, and it hasn't improved with antibiotics. And your job is to talk to the family members about the DNA CPR kind of decisions made by the medical team. So first of all, going in, we'll do a spikes perception, we'll do a brief history to understand the situation a bit better, eyes again, and a warning shot. So what we'll talk about today can be unpleasant. Do you want us to continue today, or do you want to do it in the future? Do you want other people to be involved in the chat today? And knowledge-wise, it's very important now. So the mindset behind it is that you want to show the family member why I think DNA CPR is beneficial for him. And you need to explain it in because of this, so that's why this happens, and because of this happens. So trains of why, so that they won't ask you again or keep asking like different questions, and you're like a firefighter just putting out fires in different areas, and you will lose your structure, and the whole consultation will be quite messy. So to introduce DNA CPR, what I'll do in the future is that I'll say what we'll talk about is about future plannings and the future management. So not saying now, but in the future, okay? So a summary of patient situation again, so to show that is not going well, like the whole situation is not well. And you could say like, what we want to talk about and anticipate is that in the future, John, so dad, might come back to the hospital with a worsened situation, and in those situations, the heart may stop, and it's called cardiac arrest. And ask them whether they have heard it before or not, and again reassure them that what we want to talk about is in the future. It's not gonna happen now or immediately, but what we want to do is to make a decision in advance so that there's no last minute panic and making quick decisions at that point of time. Going on to explaining DNA CPR very carefully and one step after another is that, first of all, you ask them whether they know about CPR, and you explain the good thing about it. So CPR is the chest compression, and the good thing about it is that it brings the patient back, and it is often seen in the movies or TV series. But then now you will slowly introduce your reasoning why you think it's not benefit for the patient. So you would start to talk about the bad things, the disadvantage about it in a very careful way, okay? So carefully say like, however, there are some bad things that are not often known about. The success rate is quite low, so less than 20%. Even in a young, healthy person like you and me, it's less than 20%. Not to mention dad, who is like quite frail and going through quite a lot of events. And it will involve us to break ribs. It's very invasive. Lots and lots of medication is being given. And a lot of pain might be experienced. It's unlikely for it to be successful for dad. So we think that it's not in the best interest for going through all the pain. And some people say that they want to pass away without the CPR, and it's called dignified death for them. And that's what we call DNA CPR, so do not attempt CPR. But it's really important not to let them talk at this point in time. I think it's very important for us to reassure them that it's not giving up. Okay, so tell them that it's not that we're giving up on that. It's just that when the situation of cardiac arrest, CPR doesn't sound like it's gonna work, and it has lots and lots of side effects and a lot of pain. But if the patient comes back with a chest infection, we'll treat him. If he has pain, we'll give him painkillers. But it's just a cardiac arrest that will not provide CPR. And now give them some time to process it. Silence. Does it make sense? Are you okay for me to continue? Do you understand? And then if they understand it, like a big relief in your mind, it means that you have been through the most difficult part about this whole explanation session. And what you need to do is a brief repeat of what you talked about and explain to the patient or the family member that what is going to happen now. So tell them that you could say that it's a medical decision and you would drop it in the notes, provide the leaflets, as well as let them know that we'll have multiple discussions about this kind of topics. And it's mainly to let them have an awareness of the situation and offer to explain to the family member about this decision if they wish to, and summarize the conversation at the end. And you could happily walk out that station with a big smile on your face because you have done such a good job. Going on to palliative care. So let's have a look. Let's start with another station. So 88-year-old female with a breast cancer, metastasis to bones, and in hospital due to CAP, so chest infection again, with antibiotics and not improving. So again, in terms of spikes, we'll take a brief history about the situation. And in the invitations, a friend of mine who is currently a foundation doctor already, so he is 1 year above me, he says that he likes to ask this question. So what do you think the patient is doing? So that they could say in their own words that the patient is getting worse or getting better. And again, I said, as well as some warning shots again. So a brief summary of what the mom is going through. So breast metastasis, CAP, antibiotic not improving. And what we want to talk about is future management. It can be unpleasant. Do you want me to continue today, or do you want to talk about it in the future? And now knowledge part. Our job is to show them our arguments and reasoning about why palliative care is beneficial for her. So we need to again show them the train of thought, as well as tackle each reasoning and backing up with our thoughts after our proposals each time, so that they won't ask us questions all the time. How we're going to proceed is that we'll summarize the patient's current situation and let them know that we tried everything. So we have tried everything. The antibiotic is the strongest one. We have given her, as you can see, the breathing support, and unfortunately she is not improving, or she's not going on the trajectory that we want her to be going. You could touch on whether she's gonna survive, or like she may survive, or also think about that. Or you could say, like, in the future, if she comes back to the hospital again unwell and worsen situations, we are thinking about a treatment plan called palliative care, or with the involvement of a palliative team. Have you heard of it before? Or is it okay if I continue? And you start to explain what palliative care is. So at this point in time, if they don't have any questions, it means that you did a fantastic job on explaining to them that mom's situation is getting worse already and we need something new. In terms of palliative care, what it is that it's a specialized treatment to improve the quality of life on the journey to death, and again reassure them that we're not giving up on her. It's just that it involves more things to consider, more topics to talk about and discuss in the future, as well as specialist drugs that can be given for her to relieve her pain. And explain to her about the entity that might be involved in the management, such as palliative care team, palliative nurse, social prescribers, Macmillan nurse, mental health support. And then you can let them know that what it involves is DNA CPR, the wishes, the advanced decision to reduce treatment, a treatment escalation plan, lasting power of attorney is definitely a legal document, and talk a little bit about anticipatory medications. So morphines for pain, hyoscine bromide for like secretions. But then let them know why we're talking about it and why this is being put into place, is that we'll be less panic when the situation got worse, and everything has discussed, a peaceful journey, so that they understand our reasoning behind the palliative care, okay? Again, empathy, to wait for them, some silence, and chunk and check, repeat, and a summary at the end. So overall, that's the difficult talk about DNA CPR and palliative care. For the past 3 years, so since year 3, I haven't got any DNA CPR or palliative care explanations yet as an exam, but it's just quite good to be prepared for it as a foundation doctor. Practicing that will improve your wordings and especially the silent listening, active listening. So let's go through some results that I had. So where is it? It's here. So let's have a look at the first attempt where I failed. It's the postmenopausal bleeding, and in terms of the history wise, it was okay. In terms of the social history, examiner, he said that illicit drug use could be more sensitively. I disagree on that. I think every time when I ask illicit drugs, I ask it in the same way. So this is a question I ask all patients: do you take any illicit drugs? But then, fine, whatever, just take it. Rationalize the blood test discussed. Transvaginal ultrasound done. Clarify the referrals. But you see, only after prompting from the lady. I was about to say it in 10 seconds later. Like, what can I say? But then, fine. So it's really important to let them know that what kind of structures I was about to say, and probably put the referral earlier, maybe. After listening, it's okay. Endometriosis and fibroid, also the possibility here. Yeah, at that time, because on the veneer, it says that the examination was normal, so I ruled out the HOV vaginitis already. But then, and also I didn't do much review on HOV vaginitis. Unfortunately, I missed it, and I forgot about it, so that's why I was a bit unsure. But other than that, you see, investigations discussed, a lot of details provided. I forgot to ask her to repeat back to me. I just double checked that. Does that make sense? Do you want me to continue? So probably ask her to repeat it back once. Should be a good way to show that I know about the check and check, okay? And again, need to prompt about the follow-up from specialist nurse. I do have some knowledge about PPLA and hysteroscopy. Should ask about HRT. Fine, okay. And then some points about Macmillan nurse. Fine. So you can see that overall the differential, I didn't explain it well enough, and I missed atrophic vaginitis, as well as the chunk and check and specialist referral, MTT involvement. Those are the things that I didn't do well in that station. Probably that's why the examiner didn't give me a score that I'm happy with, but that's okay. In the second attempt, it was the PEDS UTI. To be honest, I didn't know much about MCUG and DMSA scans at that time, but it's okay. Like I just said the mechanism of it, what kind of things we're looking for, and say that it's the specialist's decision whether we should do it or not. I think you need to do a MCUG as well as the scans. So you don't need to wait until the recurrent situation. If there's an event of atypical UTI in PEDS, you have to do it straight away. I forgot, I didn't know about it. I said it's specialist's decision. I'll double check with my consultant. I'm not sure whether it's okay or not in an exam situation, but I got quite a good marks for that. Probably it's because I was very safe. But yeah, so you can see that the feedback was very brief. Everything was a good and positive feedback. Very happy with it. A bit of mindset during this 15 minutes of mouth drying events. Again, you need to let the patient easy to follow where you're going. So let them know the structure of what you're going to talk about. Show them the reasoning behind this so that they won't ask you more questions about it. Less jargons. In GDM explanations, I keep using the abbreviation of GDM and OGTT. In the feedback, it touched a little bit about it and said that I should use less jargon. So probably be aware of these kind of abbreviations. Management should be correct. So that is what I was talking about for GDM. So know the management quite well. And finally, in terms of what I mean by I believe in what I say is mainly for DNA CPR and palliative care. You need to show them the reasoning why you think it's beneficial for them. And you need to believe in it and believe in your explanations. If I tried it in front of the mirror a few times about DNA CPR, and when listening back to it with a voice recording, even myself, I thought, this guy, like, what is this guy talking about? Like, it sounds so uncertain. I don't even know why we should do a DNA CPR, even after my own explanations. Have a mindset that after your explanation, you need to believe in it it should be convincing enough and understandable enough so that the person who is listening could understand the reasoning for that decision. Okay. So at the end, I want to talk a little bit about some things I learned after this unfortunate events of failing my exams. And first of all, is that the reason why you failed might be also because of you being unlucky. For my situation, it's not, I know that I didn't do well at all. I had lots and lots of problems with my differential diagnosis and the way I explain things, thinking during taking histories. So that was my problem. But when talking to people who are resitting and the feedbacks they got, the reasoning behind it, it just sounds like it's really unlucky for them. Now, 1 point away from examination. God, like it's really unlucky, bro. Or getting 0 marks for every stations, but then the feedback was everything was positive. It sounds like the examiner misinterpreted as 0 is the highest mark and 3 is the worst mark, which is just, I feel so sorry for her. So when you got your exam results and when you failed, still try to appeal it, even though the success rate of it is almost 0, but then still at least try for it. It's normal to feel upset and depressed from the results. The initial reaction from myself is that I should just continue working. It's okay, like there's nothing I can do about it. I'll never give up. Like, let's go, be strong, be a strong man. But then a week after that, there was a night shift and I was physically exhausted already. And on the way back from the night shift, I just lost all my motivations. My initial plan was to have a sleep and then start revising, doing drawing, YouTube, gym in the afternoon. But then suddenly, I just felt something snapped. And I lost all the happiness from doing the hard work. I didn't enjoy drawing at all. I just started to play random games on my PC for a week. I could say that it's sort of like anhedonia, isn't it? So lost interest of what the things I used to enjoy. And in terms of the management for that is that you need some way of releasing it, release those negative energies and complain to someone. But for my own personal preferences, I don't like to complain to others because I could sense there's a slight reduce of respect when I complain something to others. As well as when I complain to someone else, I will keep complaining for the next few days, which could be quite annoying for my audience to listen. So I found a good way of releasing it, which is to use my phone, open up the voice recorder, and say anything I want. Anything. Any swear words, any nonsense, I'll just say it in it. And I noticed that it really beneficial and has quite a good therapeutic effect on myself. Because I know that no one is going to listen to it. I don't have to be careful about what I say. As well as there's no time limit for how long I should say it for. I could say it 10 minutes. I could complain for 30 minutes. So that's my recommendations for this kind of unpleasant events. And finally, what I learned is that in this unpleasant experience, it really taught me what it meant by open. So being open to something. Previously, when I practiced with others, there are some times when I disagree with it. I would say it like I did ask this, you didn't hear it. I did check this, you missed it, and that made the other person hesitate to provide any constructive feedback, and they'll be scared of saying new things because I'll fight back. During this event, I take in as many as possible. So whatever they say, I'll take it in and ask a follow-up questions to their feedbacks to get more insight about what they feel about being a patient as well as an examiner. Listen to the site. Even though some of the feedback are not very helpful, or doesn't really suit me, or I really did ask this but you didn't hear it, but then the effect of it is that it makes the others want to help you more and will have more freedom of speech, and they will provide even more feedbacks to you. Any tiny minor details, they will mention it to you because you are mature enough to take it in, you are comfortable to talk to. So that's something I learned about the true openness. Although if going back in time, I would not want to go through this event anymore, but then it does improve my mental strength and being less fluctuated by bad news. So if you encounter any unfortunate event, I know it's very hard to stop your mindset and see the positive things that you might gain from this experience. But if you have been through it, I think a quick reflection on yourself and a journaling of what you learned throughout this process will make you gain even more from this unfortunate event and see how much you have improved, how much you have been through, and how hard you have put in for facing this kind of challenges. So that's everything I learned from this Mosler exam: history examination, investigation management and SBAR presentations, A2E assessment, communication skills, and positive mindsets that I gained from failures and unfortunate events. If there's any questions or concerns, feel free to comment down below. And thank you for watching. I'll see you in the next video. Bye!